Pancreatic carcinoma is the fourth common cause of the cancers worldwide. It is highly associated with different kinds of mortalities and morbidities because it's the most important. It's lying in the most important space, which is related to different kind of important structures, like we have discussed in the previous lecture, that there are different important vessels, inferior vena cava, aorta, portal vein, and the superior mesenteric vessels, which are located in the C-shaped curve of the duodenum, just close to the pancreas. And we have very important structures which are related to the head, uncinate process, neck, and the tail of the pancreas. So the pancreatic carcinoma is important because it has got a very high morbidity and mortality, and especially those tumors which are unresectable or that are mostly locally advanced, their mean survival, especially if we particularly talk about the locally advanced tumor, their survival is about 6 to 10 months only. And those resectable tumor which have got unresectable tumors which have got the distant metastasis, they have a mean survival of only 2 to 4 months. So that's why pancreatic carcinoma is very much important to be discussed in case of the surgical aspect. Plus, one more thing to emphasize here, that the pancreatic carcinoma, because not all the tumors, because the tumor is involving the different part. The pancreatic carcinomas, which are in the head, or the periampullary cancers, they are particularly they have got a good prognosis because actually because of their immediate or early presentation, because of the obstructive symptoms, they are actually diagnosed at a very early stage. But those tumors which are involving the body or the tail, they actually they're not diagnosed early because their symptoms do not appear early during the course of the cancer stage. So today we'll be talking about the pancreatic cancers. But before that, let me just revise a lecture from our previous, revise some steps from the previous lecture regarding the pancreatic anatomy. So we know that actually it has got the 5 parts: the head of the pancreas, the uncinate process, the neck of the pancreas, the body of the pancreas, and the tail of the pancreas. So all of the pancreas is actually lying in a C-shaped curve, as you can see in the diagram. This is a C-shaped curve of the duodenum, and mostly the uncinate process is enclosing the lower inferior compartment, and the head is actually in the middle of the C-shaped curve. The uncinate process is related to the superior mesenteric vein, which is located, superior mesenteric vein, and the artery, which is located in front of the uncinate process. And the head is related to the inferior vena cava, and the neck and the body, they're related to the aorta as well as the portal vein and the superior mesenteric vessels. And the tail of the pancreas is going into the spleen. So the hilum of the spleen, actually. It's involving the different part. First of all, we're talking about the types of the tumors, and then we'll be talking about the clinical presentation, the investigations, and then we'll be discussing about the, the surgical options in the palliative treatments and adjuvant therapy we have available for the pancreatic CA. So you can see here in the diagram that this is actually the nodal metastases, and if we particularly talk about the risk factors for the pancreatic cancer, we have divided actually into 3 groups. One is related to the demographic factors, other is related to the lifestyle, the sedentary factors, the environment, and the third group is related to the genetic factors. So if we particularly talk about the demographic factors, age is a very important constituent for that, because the peak incidence of the pancreatic carcinoma is between 60 and 75 years. And if we particularly talk about the gender, males are more predisposed to the pancreatic carcinoma. And if we talk about the ethnicity, Black African American population is because of the more sedentary lifestyle, because of more alcohol consumption, and because of their ethnicity, they're more prone to this carcinoma. So one is about the demographic factors, like the age, ranging from the peak incidence is ranging from 60 to 75 years, then the male gender, obviously, and the Black ethnicity. So if we particularly talk about the environment and the lifestyle, the smoking, the sedentary lifestyle, and the alcohol consumption. So these are three important things in our environment and the lifestyle that is actually causing that is actually a risk factor for the pancreatic carcinoma. And at the end, the main and the most important thing is the genetic factors. So family history, especially like two first-degree relatives, if they have got a history of the pancreatic cancer. So we must remember that the family history, like if there's a family history and two first-degree relatives, like in paternal, either paternal or maternal, and in the siblings as well. So the carcinoma risk is increased to 18 to 57-fold increase, right? And then another thing which is very important is like germline BRCA2 mutations. So we know that there are two important mutations which are related to the different carcinomas, like the BRCA1 and the BRCA2 mutations. So BRCA1 mutations are mostly associated with the breast cancers, and the BRCA2 mutations are usually associated, they have got a higher incidence of the pancreatic carcinoma. So and that you have to keep in mind that these mutations, BRCA2 mutations, they have a high risk in the families. And if we particularly talk about the diseases, so one entity is about the hereditary pancreatitis, and other is like the chronic pancreatitis, like because in the background of the chronic pancreatitis, and there are relapsing acute and chronic episodes as well. So because of that, there is extensive fibrosis, and we all know that because of the fibrosis and cell division and again, it helps in the development of the carcinoma. So the chronic pancreatitis is another important entity in this group. There's another syndrome which is called as a Lynch syndrome. So this is also gotten associated with a pancreatic cancer. Ataxia, telangiectasia, then we have got the hereditary polyposis adenomatous Paget syndrome, right? And then familial breast ovarian cancer syndrome, because they are moreover related to the BRCA1 and the BRCA2 mutations. So we already discussed that because of the BRCA2 mutations, this familial breast ovarian cancer syndrome, they have got more incidence with the pancreatic CA. Another entity is about the familial atypical multiple melanoma. So these diseases are related to the increased risk of the pancreatic cancer. So far we have been discussing about the risk factor for the pancreatic CA. We have divided into four main entities. One was regarding the demographic factors, like the age and the peak incidence is between 60 and 75 years, and then the male gender and the Black ethnicity, and then the environment and the lifestyle was like mostly the sedentary lifestyle and the cigarette smoking and the alcohol consumption as well. If we particularly talk about the family history, you should keep in mind that those patients having a family history or like the first degree relatives and germline BRCA2 mutations, they are more prone to the pancreatic cancers. And you should always remember the link of the diseases with the pancreatic carcinoma, like I've discussed about the hereditary pancreatitis, Lynch syndrome, familial adenomatous polyposis, and the familial breast ovarian cancer syndrome. Plus, on the background of the chronic pancreatitis, there was a more likely risk to be developed into the pancreatic carcinoma, and obviously the Paget syndrome. So keep in mind these risk factors about the development of the pancreatic cancer and diabetes mellitus, because diabetes is actually a multi system disease, which is involving, there can be macrovascular complications and the microvascular complications in case of the diabetes. So keep in mind that actually in diabetes what happens is, like, obviously there is deficient production of the insulin. Either there's a deficiency of the beta cells for the production of the insulin, or there is a resistance to this. So what actually happens is there's increased load on the beta cells. So because of that load and because of the overfunctioning of the beta cells, ultimately, they go rapid changes in cell division, and because of that, in the background of the chronic pancreatitis, ultimately they develop the pancreatic cancer. So diabetes is also another important risk factors. So if we talk about the pathology of the pancreatic cancer, always remember in mind there are multiple cancers, the type of the histopathological cancers, which can be found in case of the pancreatic cancer, right? But in 85% of the people, mostly they're ductal adenocarcinoma. And we all know that actually the pancreatic tissue is composed of the ducts and the lobules and the SNR cells as well, right? So in the ductal adenocarcinoma, what happens is, like, we know that there is a kind of a desmoplastic fibrous stromal reaction, and there is hypertrophy and the cellular and the glandular atopia. So most commonly in case of the pancreatic cancers, 85% of the tumors are the ductal adenocarcinomas, right? So you can see here in the picture, just like the prostate, we know that in case of the prostate, which is mostly a ductal adenocarcinoma, so in case of the pancreatic cell as well, most commonly is a ductal adenocarcinoma. You can see the dilated ducts, and obviously the you can see the columnar cells which have got a cellular atopia, and you can see this desmoplastic reaction because of the extensive fibrosis and extensive cell division. Actually, that stroma is that's kind of very hard and the rigid, which is called as a desmoplasia or the desmoplastic reaction. So the stroma is undergoing the desmoplastic reaction, and obviously there would be a dilatation of the duct as well, and there would be cellular and stromal atopia as well. So the ductal carcinoma is most commonly involving the head of the pancreas, and some ampullary carcinomas, they sometimes also are ductal adenocarcinoma, but keep this thing in mind that mostly it's involving the head of the pancreas, and in 85% of all the tumors, mostly the tumors are ductal adenocarcinomas. There's another entity, like there can be some carcinoid tumors, some neuroendocrine tumors, and the cystadenomas as well. In case of these pancreatic cancers, which are obviously not very common, but they have some kind of representation in case of the pancreatic cancers. So there are two types of the cystic tumors, serous cystadenoma and the mucinous cystadenoma. Usually these serous cystadenomas, they are particularly benign, and they are mostly small and multiples, but the good thing about them is their course is benign. But if we talk about the mucinous carcinomas, so mucinous carcinomas, they have a very high potential for malignancy. And we divide actually these mucinous carcinomas into two entities. One are the simple mucinous cystadenomas, and others intrapapillary ductal mucinous neoplasias, right? So you can see actually in the diagram, this is the sheath of the mucin cells. You can see. So mostly we divide the cystic tumors into two categories. One are the cystic, serocystic tumors, which are usually benign. They're smaller in size, they're multiple, and they're more common in the perimenopausal woman. And the other entity, which is like the mucinous, they are benign. They're not benign, they're actually malignant, and they're divided into two categories. One are the simple mucinous mucinous cystadenomas, and the other is intrapapillary ductal. So the simple mucinous neoplasias, they are more common in the perimenopausal woman, and the other entity, intrapapillary ductal, the mucinous neoplasias, they're more common in the older men, and they are multiloculated, and they have got a thick wall as well, and mostly they have a high potential to develop into malignancy. So there can be some other tumors as well, which are the ampullary adenocarcinomas. So the tumors which are involving the ampulla of the vater, or the tumors which are arising from, we know that actually the ampulla of the vater is in the second part of the duodenum, and it's actually acting as a sphincter, because that sphincter of the Oddi that also present around the ampulla of the vater, and the main pancreatic duct, and the common bile duct, actually that is draining into the second part of the duodenum. So if you talk about the ampullary adenocarcinomas, so they're rising from the ampulla of the vater, and obviously they are the adenocarcinomas, so they have the origin from the columnar epithelium. You can see here in the diagram as well that these are the ampullary carcinomas, and you can see the cellular atypia, and you can see the high nuclear to cytoplasmic ratio, and you can see the columnar cells in this histopathological slide as well, and you can also see the mitotic division of the ampullary adenocarcinomas as well. So before talking about the clinical features, one thing I want to discuss here is about the spread of the tumor. They have got four means. The pancreatic cancers, their spread can be local. And if we talk about the local spread of the tumor, mostly it's involving the important structures, like maybe involving the duodenum, or the liver, or the bile duct, or it's involving the vena cava, the aorta, or the superior mesenteric vessels. So one is the local spread, the other is via the lymphatics, the other is via the along the nerve sheath as well, and the fourth route of spread is through the blood vessels, right? So one is the local spread, the other is through along the nerve sheath, the other is through the lymphatics, and the fourth route for the spread of the tumor is the blood vessels. Plus, liver metastasis and the peritoneal metastasis, because there can be peritoneal seeding as well. So keep in mind that there can be liver and metastasis, and there can be peritoneal seeding in case of the pancreatic cancers. So regarding the clinical features for the pancreatic cancer, always remember in mind that sometimes there can be those patients which are symptomatic, and there can be those patients which are asymptomatic, or some they have got general non-specific symptoms, and the other they have got the specific symptoms. So first we'll be talking about the general, because if the patient has not symptoms related to the location or the landmark and the obstructive symptoms for the carcinoma, so the other, like the decreased appetite, the weight loss, the cachexia, and on and off, mostly they're not painful, they're not painful, they're usually painless. But sometimes when there's involvement along the nerve sheath, they become painful as well. So the general non-specific features would include the weight loss, anorexia, cachexia, and emaciated kind of a look of the patient. And obviously, he'll be giving you the symptoms of nausea as well. But sometimes those cancers, like the periampullary cancers and the cancers related to the head of the pancreas, because they are actually in a point where they are related to the duodenum, and we know that in the second part of the duodenum, the bile duct and the pancreatic duct, they are draining into the the major duodenal papilla and the ampulla of the Vater. So what happens is, like, those tumors which are involving the periampullary region or the head of the pancreas, they present with the obstructive symptoms, because when there would be obstruction of the common bile duct, there would be jaundice. So the patient, the first presentation would be jaundice. Usually there is a painless jaundice, but sometimes in the later advanced stages, when there is a nerve sheath involvement, then they become painful. So there would be jaundice, there would be, you can see the jaundice or in the skin, the darker coloration of the skin, the darker color of the urine, the dark color of the stool. There would be steroria, because there would be, obviously, because of the deficiency of the bile, there would be no absorption of the fat, and obviously they will lead to the steroria and greasy, cheesy kind of a stool, and the patient will obviously give you the history of the weight loss and anorexia as well. So we'll be discussing these symptoms one by one. So the first presentation would be the jaundice, and it would be a kind of a, because in case of the acute pancreatitis, if it's a biliary pancreatitis, and then the patient will present to you with a jaundice as well. But how to differentiate if the jaundice is related to the pancreatic CA or acute pancreatitis? So I have to differentiate, because that would be a painful jaundice. In case of the acute pancreatitis, the patient will give you the history of pain in the epigastric region, right? But in case of the tumors which are not locally advanced or which are not metastatic, and they are in the early stages, so there would be a painless jaundice. Obviously, there would be nausea, there would be epigastric discomfort. Now the discomfort is different from the pain, right? Because there obviously there would be some kind of the generalized neoplastic syndrome effects on the patient as well. So the patient will present to you with the epigastric discomfort. There would be pruritus. Why there would be pruritus? Because obviously the bile is not excreted, right? So there would be no absorption, and because of the stasis of the bile, the patient will have the pruritus. And sometimes when there is distant metastasis and the liver is involved by the metastatic cells, and obviously the function of the liver is also being compromised. And whenever the function of the liver is compromised, the patient will give you the history of maybe because there would be the liver is synthesizing the clotting factors. So he can give you the history of bleeding, or he can give you the history of the different kind of patches or the spots in the body because of the deranged coagulation profile. Obviously, because of the increased secretion of the bile in the urine, there would be darker color of the urine, there would be steroria, there would be weight discomfort, there would be weight loss, and there would be back pain. So always remember in mind that when the patient is complaining about the back pain, always think in your suspecting CA of the pancreas, always think about the retroperitoneal seeding of the cancer, right? So sometimes those tumors which are involving the body or the tail of the pancreas, they do not present with the symptoms of the obstructed jaundice. They have got vague symptoms: weight loss, cachexia, nausea, epigastric discomfort, right? But those tumors which are involving the ampulla of the Vater or the head of the pancreas, they are mostly symptomatic. And the symptoms related to these cancers is the jaundice, which is a painless jaundice initially. There would be darker color of the urine, there would be darker color of the stool, there would be steroria, and there would be fat malabsorption, nausea, epigastric discomfort, pruritus, and there would be a liver involvement. Obviously the coagulation profile, because of the abnormality with the coagulation profile, so, and the deficiency of the clotting factors, because of that, actually, the patient will complain about the bleeding diastasis as well. And there would be history of the weight loss, and there would be history of the back pain if there is a retroperitoneal seeding of the tumor. So this was about the clinical features. So you, by your history and by the clinical examination of the patient, sometimes when you're examining the patient, obviously you have to go do the general physical examination. You'll look up for the jaundice, and you'll look up for the tinge and the darker coloration of the skin and all these things after you're done with your history part. So the most important thing in case of the pancreatic cancer is like to do the abdominal examination, right? So sometimes those tumors which are larger in size, they can be palpated as a mass, right? But usually, because we all know that pancreas is a retroperitoneal structure, so it is less likely to get a mass or to palpate a mass in case of your general abdominal examination, right? So after the history, the first important thing you're going to do is the examination of the patient, and you're also going to look for the tenderness, because you have to differentiate the carcinoma from the pancreatitis, right? Now, how are you going to investigate a patient with all these symptoms? Maybe a patient presenting to you with the obstructive symptoms. There would be jaundice, and there would be epigastric discomfort as well. There would be history of the weight loss, and all these things. Now, how are you going to investigate that patient? For the investigation, obviously, you always start from the very baseline investigations, right? So you're going to go for all the basic baselines, like you'll go for the complete blood count, you go for the ESR, CRP, you go for the LFTs, RFTs, and serum electrolytes as well. And then you're going to go for the urinary and all those ECG and chest X-ray and all the basic. Now, what are the investigations which are important in case of the pancreatic CA? So investigation is like, number one is the LFTs, because if the patient is presenting to you with the coagulation profile as well. So first and the foremost important thing are the LFTs, which are the liver function test. So you're going to look for the bilirubin. Obviously, the level of the bilirubin would be raised, and then you're going to order for the direct and the indirect bilirubin, or gamma GT as well, to differentiate either it's the cause of the bilirubin is hemolytic, because there can be hemolytic jaundice, so you're going to differentiate it from the obstructive jaundice. So first of all, to differentiate the hemolytic jaundice from the obstructive jaundice, what you're going to do is you're going to order for the direct and the indirect bilirubin, and the obviously the gamma GT as well. And then you're going to go for the serum amylase to differentiate if the patient is presenting to you with the epigastric discomfort. Then what you're going to do is you're going to obviously differentiate acute pancreatitis from the CA pancreas. And after that, when you're done with your baseline investigation, and you actually found out to have the deranged RFTs, then the other investigation you're going to order is the ultrasonography. So usually, a mass in the pancreas can be easily picked up by the ultrasonography. And if there is no mass, which is being picked up by the ultrasonography, and then the CT, computed tomography, is the choice of the investigation for the and always go for the contrast-enhanced CT scan for the pancreas. And other investigation is like the ERCP. First is the MRCP, magnetic resonance cholangiopancreaticography, for the visualization of obviously the tract, and if there would be obstruction or the mass is usually visible in the CT, but sometimes there can be ERCP, because what you're going to do is through ERCP there can be therapeutic and there can be diagnostic as well. So in case of the diagnostic, ERCP, you can take the brush cytology or the biopsy. So first, about all the baseline investigation, the most important thing, the most important thing is like the LFTs, which are the liver function test, and serum amylase and lipase as well. And obviously, the other thing important is the PT, APTT-INR, which is the coagulation profile, telling you about the status of the liver. And then you're going to move for the ultrasonography. And if there is a kind of a mass, but at the pancreas, so actually to see exact location and the involvement or the like distant metastasis or the status of the lymph nodes or the relationship of the mass with the other retroperitoneal structures, relationship with the duodenum, and the important structures like the vena cava of the mass is compressing all those tumors or not. So you're going to go for the contrast enhanced CT scan. Then MRI and MR angiography, sometimes it's helpful, but especially in case of those tumors which have got a vascular invasion. So MR and MR angiography is usually helpful in those cases. Then ERCP and biliary stenting, right? So ERCP, actually you go endoscopic retrograde cholangiopancreatography. And in that, what you do is actually you put the scope, like obviously you're putting the endoscope in, you can go for the therapeutic biliary stenting, the drainage of the bile, or the other thing is you can take a brush cytology or the biopsy as well. Then another thing which is important is endoscopic ultrasonography. So there are some indications for the endoscopic ultrasonography. So what are the indications for the endoscopic ultrasonography? If the mass is not visible on ultrasound, the CT, and you're still suspecting a mass, then you can order for the endoscopic ultrasonography. Then you have, if you are confused about a pseudocyst and the carcinoma, then you can go for the endoscopic ultrasonography. To differentiate between the pancreatic cancer and the chronic pancreatitis, you go for the endoscopic ultrasonography. And the fourth indication for the endoscopic ultrasonography is a vascular invasion, right? So always remember that there are 4 indications for the endoscopic ultrasonography. One is when the tumor is not visible in the CT scan. Other is the vascular invasion. Number 3 is to differentiate the chronic pancreatitis from the CA pancreas, and to differentiate between the pseudocyst from the other cystic tumors like the cystic adenomas, serous, or the mucinous cystic adenomas, right? And sometimes you need a core cut, true cut biopsy, or you need FNA. Then you go the transduodenal. You take a transduodenal or transgastric FNA or true cut biopsy. But sometimes you can order for the percutaneous transperitoneal biopsy. Now, this transduodenal and the transgastric FNA is better as compared to the percutaneous transperitoneal biopsy. The reason being, because when you're going through the skin and you're puncturing the skin, there are more chances to develop a peritoneal seeding, right? So in those tumors in which there is no peritoneal seeding already, and you are doing a percutaneous transperitoneal biopsy, you're taking that, then there is a chance that you are actually converting that localized tumor into a peritoneal seeded tumor, right? So the transduodenal and the transgastric FNA or the biopsy is more safer as compared to the percutaneous transperitoneal biopsy. And obviously, and then the histological confirmation. So start from the baseline investigation if you're investigating a case of the pancreatitis or the pseudocyst or whatever with those features, right? So start from the baseline, go for the blood CP, order for the LFTs, and if the LFTs are deranged or even normal, and if they are deranged, then you have to differentiate the cause for the jaundice, right? And you have to order for the gamma GT and the direct indirect bilirubin. You're going to go for the serum amylase level as well and the coagulation profile. So on the basis of your investigation, you go for the ultrasonography, then you move to CT scan, which is a gold standard. And sometimes you go for the ERCP and biliary stenting as well. You take the brush cytology or biopsy. And I already told you the 4 indications for the endoscopic ultrasonography. And at the end, if you want to take a trocar biopsy or you're going to go for the FNA, the transduodenal or the transgastric FNA is preferred as compared to the percutaneous because they're more likely chance for developing a peritoneal seeding with the percutaneous transperitoneal biopsy, and obviously the histological confirmation. And the other thing is a diagnostic laparoscopy. Because if actually the diagnostic laparoscopy save you from the the consequences of exploratory laparotomy, because sometimes you're not sure about the status of the pancreatic cancer, like the distant metastasis, and you have opened up the patient with a laparotomy, and there's an involvement of the vein. What next you're going to do? Obviously, that's a kind of unresectable tumor. So in case of the unresectable tumor, the only option left is like close the abdomen again. So it actually save you if you do a diagnostic laparoscopy before, so you can see actually that there's a seeding in the veins as well. There's a seeding in the hepatic artery. So obviously you don't have to give a multi-line incision and to open the patient, because we know that you cannot resect the tumor. The tumor is inoperable, right? So these are investigations, the endoscopic ultrasonography, and obviously the ERCP. This is a picture from the ERCP, and this is the endoscopic ultrasonography. So one thing which is important, that you have to differentiate the tumors, whether they're resectable tumors or they are unresectable tumors, right? So these are the 2 categories, and you decide your surgical resection on the basis of these things. Either the tumor is unresectable or inoperable, or the tumor is resectable. Now, those tumors which are involving the portal vein, which are involving the hepatic artery, which are involving the superior mesenteric artery, they are inoperable, or there is a metastasis to the liver, or there is a metastasis to the main vessels, IVC as well. So they are inoperable tumors, right? Those tumors which are involving the veins, because now it depends upon how much the segment of the vein is involved. If the segment of the vein involved is less, then you can just remove that part of the vein and you can go for a graft, right? So those tumors which are involving, or their distant metastasis into the artery, right? Or there's a distant metastasis to the lymph nodes, or there's a distant metastasis to the liver, spleen and the duodenum, then those tumors are not resectable. But those tumors which are involving the vein or the spleen or the splenic artery or the splenic vein, they are resectable tumors. So first, what you have to do is you have to identify those tumors which are not resectable. Obviously, you have to put the patient on adjuvant therapy or the palliative care, right? So it is important to differentiate between the resectable and non-resectable tumors. Mostly, these pancreatic cancer present to you usually in the later stages when they have already locally advanced, or there's a distant metastasis, because sometimes those tumors which are involving the body and the tail, they have got a vague symptoms. So usually they are diagnosed very lightly. So if we talk about the surgical resections, the options we have available is like, the pylorus preservation pancreaticoduodenectomy, and the other, the surgical option is the Whipple's procedure, and we combine it with the adjuvant therapy, and then there are the palliative therapies as well. So talking about the surgical resection, the one and most commonly performed is a pylorus preserving pancreaticoduodenectomy, original pancreaticoduodenectomy, which is the Whipple's procedure, and then the total pancreatectomy and the pancreatectomy with the splenectomy. and the distal pancreatectomy. So now these are the surgical options we have available, and that surgical option is related to the extent of the tumor, right? If you have already identified that actually the tumor is resectable or not resectable. So if the tumor is resectable, and in case of the pylorus preserving pancreatic duodenectomy, you remove the head of the pancreas, you remove the second part of the duodenum, then also the regional lymph nodes, and the pylorus. There's some part of the stomach is also removed in case of the pylorus preserving pancreas. Like it means that the gastric antrum is being preserved, right? What do you do in a regional pancreat? Actually, this regional pancreatic duodenectomy is a Whipple's procedure because it was originally given by the surgeon whose name was Whipple. So Whipple procedure, the head of the pancreas with the duodenum and with the regional lymph nodes, and obviously the bile duct is also resected. The distal part of the bile duct is resected, and the antrum and pylorus of the stomach, they both are resected. So actually, Whipple's is separate from the pylorus preserving pancreatic duodenectomy because in Whipple procedure, actually gastric antrum and the pylorus both are removed along with other structures. But in case of the pylorus preserving, the pylorus is preserved and the gastric antrum is also preserved. So that's the difference between the pylorus preserving pancreatic duodenectomy and the Whipple procedure. So it has no effect on the prognosis or the mean survival rate of the patient, but it is actually, the physiological effects, they are more conserved in case of the pylorus preserving pancreatic duodenectomy. So those tumors, usually, which there can be, you can perform the total pancreatectomy as well. Those tumors which are locally advanced more, and they're involving the head and the body and the tail, then obviously the choice is a total pancreatectomy. And sometimes those tumors which are involving the body and the tail, you go for the pancreatectomy with splenectomy, and for the distal tumors of the pancreas, you go for the distal pancreatectomy. So depending upon the location of the tumor and the distal metastasis of the tumor and the local status of the tumor, you decide the surgical resection, right? Okay, so if we talk about the pancreatic duodenectomy, which is the pylorus preserving pancreatic duodenectomy, what you do is you have to mobilize the duodenum, you have to mobilize the head of the pancreas, you have to mobilize the fourth part of the duodenum from the transcolic fracture, right? So what you do is actually, you can see here in the diagram that this esophagus, this is the stomach, and this is the duodenum, right? And in the sage shape of the duodenum, there is a pancreas. So in case of the pylorus preserving pancreatectomy, what you remove is you remove the distal part of the bowel, because you start from the cholecystectomy. What you do is you resect you remove the gallbladder, and you also the distal part of the bile duct, common bile duct, that's also removed. So the proximal part is anastomosed with the jejunum, and the pancreas, the head, and some part of the body of the pancreas, some part of the neck of the pancreas is also resected. So choledochojejunectomy, like you are anastomosing the proximal part of the common bile duct with the jejunum, and so choledocojejunectomy, and obviously you are a pancreatic jejunectomy because the remaining portion of the pancreas is anastomosed with the jejunum. So this is a two procedure stage. You start from the cholecystectomy, you remove the gallbladder, you remove the distal part of the bile duct, and you anastomose with the the proximal part of the bile duct with the jejunum, which is called as a cholecystectomy. And you resect the pancreatic head by mobilization of the spleen and the mobilization of the second part of the duodenum, and you resect the the pancreatic part, which is involved in the tumor, and you anastomose the remaining part with the jejunum, right? So whole of the duodenum is removed, right? So in pylorus preserving pancreatectomy, you remove the distal part of the common bile duct, you remove the gallbladder, you remove the duodenum, and you remove the pancreas as well, the part which is involved. So ultimately, you build up the choledochojejunostomy, and you do the pancreaticojejunostomy in case of this. So you can see here that this was actually the part of the tumor which was involved, like the uncinate process, the head and the neck, and the body and the tail is preserved. So in case of the pylorus preserving surgery, the duodenum is resected, this part is resected, and sometimes if there's involvement of the veins as well, then what you do is you resect the part of the vein and you put a graft on the vein as well, depending upon that. But if there's involvement of the after, you have to go for this pancreatic duodenectomy after deciding if the tumor is operable or not. So we're just discussing about those operable tumors. Obviously, there would be no involvement of the veins as well. So in a conventional pylorus preserving pancreatic duodenectomy, distal part of the bile duct, the gallbladder, the duodenum, and some part of the head uncinate process and the neck of the pancreas is removed, and you make a choledochojejunostomy and a pancreaticojejunostomy in this procedure, which is called the pylorus preserving. So you can see in the diagram that this is the distal part of the bile duct, which is being anastomosed with the jejunum, because whole of the duodenum is being removed, right? So this is a choledochojejunostomy. And you make an anastomosis with the remaining part of the pancreas with the jejunum, which is the pancreaticojejunostomy. Sometimes you have to give the adjuvant therapy after the surgical resection of the pancreas. So the options for the adjuvant therapy is like the chemo and the radiotherapy. In case of the chemotherapeutic agents, the option is a 5-fluorouracil or gemcitabine, and these are mostly combined with the radiotherapy. Those tumors which are inoperable, or they are usually, they have got a distant metastasis, or they're locally spread. In case of those patients, you put the patient on palliative therapy. So the palliative therapy can be medical palliation, or it can be surgical palliation. So in case of the palliation therapy, and if the tumor is inoperable, then you can just do the ERCP, and you can do the biliary stenting. And if the ERCP biliary stenting is not possible, then you can go for the percutaneous transhepatic biliary stenting as well, if the status of the patient allows you. So the palliation is a surgical. Basically, you can make a gastrojejunostomy, or you can make a duodenojejunostomy or jejunojejunostomy, because just a kind of a surgical bypass. So one option is the surgical biliary bypass by creating a gastrojejunostomy or jejunojejunostomy, and you can do the biliary stenting either through ERCP if the patient status allows you, and if the patient status doesn't allow you, then you can go for the transhepatic percutaneous biliary stenting. Or you can go for the surgical gastroenterostomy, or you can go for the jejunoenterostomy as well. And obviously, you can put the patient on a medical therapy as well, giving a good analgesia or celiac plaque bog, or there can be transthoracic splanchnicectomy. There are basically the palliative surgical options you have available. encourage normal activities, enzyme replacement for the steroidea, or treating the diabetes, and obviously considering the chemotherapies as well. So this palliation therapy is just, because those tumors which are, locally malignant, they are locally metastasized, their survival is only 6 to 10 months. So what you can do is only to give a palliation therapy. And for those tumors which are, they've got a distant metastasis, so their survival is even worse, like 2 to 6 months. So you can offer them a palliation therapy by surgical bypass, gastroduodenostomy, or the gastroenterostomy, ERCP biliary stenting, or giving a medical palliation therapy. And ERCP is another important technique. By you just have to put a T-tube through the ERCP, and that's actually draining and kind of giving a symptomatic relief to the patient. So these stents can be actually metallic, or they can be plastic. So, or they can be mesh metal stents in the bile duct you have to place, and you have to now just keep the duct draining and giving a symptomatic relief to the patient. Or they can be percutaneous approach. I already told you, percutaneous transhepatic. You go through the liver and you put a stent in the bile duct and keep the duct draining. So the ERCP is helpful in case of the palliation therapy. In case of that, because you can either put a plastic stent, or you can place a metal stent with a mesh. So it's actually draining and making the patient symptomatically better. So this was about today's topic. We have discussed about the CA pancreas, and then we have also discussed about the clinical features and the surgical and the palliation options we have available in case of the pancreatic cancers. So that's all for today. Thank you for watching sqadia.com.